Welcome to The Explainer. Today we're tackling a seriously high-stakes area of pediatric oncology, and that is distinguishing and managing two of the most critical childhood abdominal tumors, Wilms tumor and neuroblastoma. When a young patient comes in with an abdominal mass, the clinical path you choose in those first few hours, it can literally change their life. So, knowing the nuances between these two conditions is absolutely crucial. Let's get right into it.
Okay, picture this scenario. A parent is giving their toddler a bath, just a normal evening routine, and suddenly they discover a firm, painless mass in the child's abdomen. They're panicked, obviously, and they rush the child into your clinic. As a healthcare professional, what is the absolute first thing you must not do? It's a classic clinical mystery, and it perfectly sets up our tale of two very different tumors that can present in some frighteningly similar ways. We're going to solve that mystery right now.
So, here's our roadmap for today. 1. Two pediatric abdominal tumors. 2. Wilms tumor. 3. Neuroblastoma. 4. Comparing diagnostics and treatments. And 5. Managing chemo and radiation side effects. Let's start with Section 1. Two pediatric abdominal tumors, the clinical mystery. We really need to establish the foundational differences between these serious yet highly treatable childhood cancers.
Think about the fundamental anatomical dichotomy here. It's like a fork in the road. On one side we have Wilms tumor, also known as nephroblastoma, and this guy originates directly in the kidney. On the flip side, we have neuroblastoma. Now this one arises from immature nerve cells. Because it's a tumor of the sympathetic nervous system, sure, it can appear in the adrenal gland, but it can actually show up anywhere along the sympathetic chain. We're talking the retroperitoneal area, the head, neck, pelvis, or even the chest. So preventing clinical confusion starts right here, just by knowing exactly where they originate.
Moving on to Section 2, Wilms tumor, kidney origin, encapsulated and incidental. Let's look at exactly how this specific tumor behaves. So, Wilms tumor actually arises from embryonal kidney tissue that just failed to fully differentiate during fetal development. Basically, it just continues to proliferate after birth. Most of these cases, we're talking about 2/3 of them, happen in kids under age 5, and it is overwhelmingly unilateral. Only about 5 to 7% of cases affect both kidneys. Now, going back to our opening scenario, this painless, firm, non-tender mass is classically found incidentally by caregivers. They're just bathing or dressing the kid and they feel it. While it is usually localized, you have to be on high alert for associated clinical findings. Keep a close eye out for hematuria and specifically hypertension. You should always monitor for hypertension in any child hospitalized with this diagnosis. And a crazy stat to keep in mind: 90% of Wilms tumor cases have absolutely no known risk factors. Only about 10% are tied to family history or some rare congenital syndrome.
Now listen to me closely on this one. If you take nothing else away today, remember this crucial point. Do not palpate the abdomen. If you even suspect a Wilms tumor, this is your single highest yield safety rule. The tumor is encapsulated, so if you palpate it, even just during routine stuff like bathing, dressing, or repositioning, you literally risk rupturing that capsule and spilling malignant cancer cells all throughout the child's body. This applies to every single physical assessment and caregiving interaction. It is strictly hands-off until the care team has fully evaluated it.
Once you have that diagnosis, the clock starts ticking fast. 48 hours. That is the standard, rapid clinical window for getting in there and surgically removing the tumor and the affected kidney. Prompt surgical resection is the definitive best practice here. And families need to be prepped for this, right? They need to know this incredibly fast turnaround is expected and that further treatments are going to start practically the second the surgery is over.
All right, Section 3, Neuroblastoma, the metastasized threat, adrenal and sympathetic origins. We're shifting away from the encapsulated nature of Wilms to a much more aggressive clinical picture.
Like Wilms, neuroblastoma is almost always diagnosed in kids under 5, mostly between ages 1 and 2. But honestly, that's where the similarities stop. Because it arises from the sympathetic chain, sure. A palpable abdominal mass is common, but the overall presentation depends entirely on where it's located. But here's the most sobering distinguishing fact. Unlike Wilms, neuroblastoma is usually already metastasized by the time you find it. It's just a completely different, much darker pattern. Instead of a healthy-looking kid with an incidental mass, you're looking at systemic signs: weight loss, anorexia, diaphoresis, and real signs of metastasis like jaundice, dyspnea, facial or neck edema, or even dark pigmented skin nodules on their extremities.
Section 4. Comparing diagnostics and treatments, differentiating the path forward. Let's talk about how we definitively separate these two in the lab and treat them.
Diagnostics are the key to telling these two apart. For Wilms tumor, we rely heavily on abdominal ultrasounds, CT scans, and an inferior vena cavagram to make sure the vena cava isn't involved.
But neuroblastoma, you're hunting for specific markers. You want to check urine catecholamines, specifically vanilla mandelic acid and homovanillic acid. You're also going to need a bone marrow biopsy to check for spread and an MIBG scan to see if there's bone and soft tissue involvement. Treatment-wise, surgery is huge for both. Wilms needs that prompt resection within 48 hours, often followed up by chemo agents like dactinomycin and vincristine. For neuroblastoma, surgical resection is still the treatment of choice, but because it's usually already metastasized, these poor kids face an intense, multimodal regimen of both chemotherapy and radiation.
Which brings us to Section 5, Managing Chemo and Radiation Side Effects, Holistic Pediatric Oncology Nursing. No matter which tumor the child is fighting, they're facing a grueling treatment process that demands top-tier nursing management.
Let's break down our nursing responsibilities, starting with a true emergency: chemotherapeutic extravasation. This is when those highly toxic chemo agents leak into the surrounding skin and tissue, causing severe, rapid damage. If this happens, your actions have to be immediate. Step 1, stop that infusion the absolute second you see redness or irritation. Step 2, apply ice to the site. This constricts the blood vessels and keeps the drug from spreading further. Step 3, notify the provider immediately. You don't hesitate, you don't wait and see. It's rapid patient safety in action.
And this brilliantly illustrates the depth of holistic care required way beyond just watching an IV site. We have some heavy systemic effects to manage. Take hemorrhagic cystitis, for example. To prevent this, give the chemo early in the morning, push fluids all day, encourage frequent voiding, and administer the protective drug Mesna to shield the bladder. For that debilitating nausea, don't wait for it to happen. Administer antiemetics like ondansetron prior to starting therapy. For loss of appetite, keep a close eye on their daily weight and offer small, frequent, high-calorie, high-protein meals. If they want ice cream or milkshakes, let them have it. Watch out for foot drop, which causes weakness and numbness, and make sure you're assisting the child with ambulation so they don't fall. And if they're getting radiation, make sure caregivers know they cannot put lotion on the radiation site, as it can seriously irritate the skin.
As we wrap up this explainer, I want to leave you with something to really think about. We've gone over some rigid clinical rules today, like literally never palpating a Wilms tumor. And we've covered the intense medical management needed for metastasized neuroblastoma. But these families are going through the worst days of their lives. They need honest, non-judgmental support, absolutely no false reassurance. So here's my question for you. As a pediatric oncology caregiver, how will you balance the strict, life-saving physical safety of these children with the profound emotional support their families desperately need during those terrifying first days of diagnosis? It really is the ultimate challenge in pediatric care. Thanks so much for joining me today, and keep that question in the back of your mind as you take these critical concepts out into the field.